Okay. So, welcome everyone. Thank you for joining us today. Again, my name is Brenda Helgett. I'm Executive Director of A Time to Heal. I want to say thank you to our wonderful sponsor, Nebraska Cancer Specialists. They sponsor each one of our Create Your Best Life events, and they're the reason that you have the opportunity for free continuing education today. So for more information, just please visit their website at nebraskacancer.com. And thank you once again to them and their generosity. So joining us today, we have Dr. Megan Oakes. Dr. Oakes is a board-certified reproductive endocrinologist. She attended the University of North Carolina at Chapel Hill and received her medical degree from the University of Nebraska Medical Center. After graduating with honors from UNMC, Dr. Oakes completed her obstetrics and gynecology residency at Oregon Health and Science University. While at OHSU, she was awarded the Excellence in Residency Award by the American Association of Gynecologic Laparoscopists. That's really hard to say. Dr. Oakes' fellowship was completed at the University of Michigan, which so highly regarded that university. And she returned to Omaha in 2009 to begin work with Methodist Reproductive Health Specialists, and she served as their assistant clinical professor in the Department of Obstetrics and Gynecology at Creighton. She is currently working at Heartland Center for Reproductive Medicine in Omaha, Nebraska. So without any further ado, Dr. Oakes, thank you so much for coming, and we are so eager to hear the answers to all of our questions today.
Well, thank you. That was quite the introduction. I was just gonna give everybody my name and tell them I was in Omaha, but thank you. Okay, well, thank you everybody for taking time out of your Saturday morning. I'm sure you have busy schedules and other things you could be doing, or maybe would like to be doing, but we appreciate you attending, and hopefully you'll find it both interesting and educational. The whole presentation is designed to be very casual and very fluid. So if you do have questions, feel free to enter those in the chat as we go along. Hopefully we'll have some time at the end that we can devote just to questions as well. Brenda and her team were nice enough to kind of put together a list of maybe the most or some of the most common questions that patients tend to have about their cancer treatment, the potential effects of the cancer treatment, menopause, that sort of menopause transition. And so I went through and kind of, at least for my perimenopausal brain, arranged them in a way that I thought flowed. And so we'll kind of go through those one at a time. And then towards the end, transition a little bit away from cancer and menopause and a little bit more to cancer and fertility on the backside, right? What does fertility look like post-cancer treatment? And if all of our conversations take longer than we thought, we can always schedule another one of these that just talks about fertility. Okay, so I just, before we get started, wanted to define a couple medical terms, because I think people sometimes in speaking or in doing Google searches use words that maybe medically aren't the accurate term or the accurate search term. And it's easy to then get get information that's not applicable to you or is confusing. So when a physician talks about menopause, what that means in the strictest sense of the word is that woman has been 12 months without a period in conjunction with abnormal hormone levels, okay? So it is what we would call a retrospective diagnosis. When a woman has been without her period for 4 months or 5 months and comes in and says, am I menopausal? The correct answer would be, I don't know. I can't tell you you're menopausal until it's been a year. And so that means if, as a woman, you go 11 months without a period and then you get one, you are technically not menopausal, and that clock starts over. When you hear people talk about the symptoms of menopause and the hot flashes and the night sweats and all of the difficulties with it, they're frequently referring to the perimenopausal transition, okay? So that period of time leading into menopause. The average age of natural menopause in the United States is about 51.4. When you talk about the perimenopause or the menopausal transition, that's going to be the several years of time leading up to menopause where hormone levels can be wildly fluctuant, menstrual cycles can be all over the place, but you are not technically menopausal. And when that happens, when a woman goes through that transition prior to the age of 40, the medical term is called premature ovarian insufficiency. Okay, and that is just sort of that premenopausal transition happening at an earlier age. Okay, so the first question that I was posed, what are the potential causes of early menopause? And there's a whole bunch of causes, right? But I think for purposes of our conversation, we're focused on potential causes related to cancer. And so when you think about cancer treatment, you think about chemotherapy, okay? Some of the chemotherapeutic agents can result in early perimenopause or early menopause. Not all of them will do that. The ones that we as physicians worry most about are a group of agents called the alkylating agents, which everybody's like, I don't know what that is, but the most common one is cyclophosphamide. And that is what you would hear from your doctor, cyclophosphamide. The other group that we're really concerned about are the drugs that are platinum based. So if you're taking a medication or a medication is recommended that has platinum at the end, carboplatin, cisplatin, those are going to be more concerning. And the reason that chemotherapy is so hard on the ovaries is because cancer is basically uncontrolled cellular growth and proliferation. And so chemotherapeutic drugs go in and they actually focus and attack on the cells in the body that are rapidly dividing. That's how they know the chemotherapy knows which cells to hit. And so the thing about the ovary is the eggs that are in the ovary are also rapidly dividing. And so eggs are really uniquely susceptible to the effects of chemotherapy in ways that like other organs and tissues in the body aren't. So chemotherapy is a big one. Radiation. So women who have to undergo like pelvic radiation because of a specific type of cancer, maybe endometrial or cervical or vaginal, or women who have to undergo total body irradiation for, say, like a stem cell transplant. Radiation, very hard on the ovaries. And then the last big one would be surgical menopause. So women whose ovaries had to be removed as part of their cancer diagnosis. Those are sort of like the three big ones. There was sort of a corollary question to that, which was, well, how do I know if the loss of my periods is due to menopause? And that can be a little bit more challenging when people have cancer, because when women have severe illnesses, their periods can go away. When women lose weight, their periods can go away. When women are under extreme stress, their periods can go away. And cancer pretty much does all three of those. And so there is this sort of question, if the periods go away during treatment, is that a side effect of your illness, or is that a long-term result of your treatment? And to some extent, time will tell, right? Sort of frustrating to not always be able to have that answer in the moment. But sometimes you just have to get to the other side of the cancer treatment and then see what happens. But things that you can be looking for in terms of like, is this menopause or are my cycles going to come back, is obviously, do my periods come back? Am I bleeding? Or am I noticing other signs and symptoms in my body that I used to associate with my period? So if you're a woman who 3 days before your period starts getting back pain, and then you start getting cyclical back pain every month again, that's a good sign. If you're a woman who gets a migraine every week before her period, and those migraines come back every month, that's a good sign. If you really want more, I guess, like quantifiable information, then that would probably mean going to your oncologist or your OBGYN and saying, hey, can you do some blood testing and see where my hormone levels are and tell me what this looks like?
Dr. Oaks, can I ask a quick question? And for
Yeah.
those that don't know, I'm also a cancer survivor, and I also got thrown into early menopause, I guess you could say, or now I know it's perimenopausal symptoms. But can we go back just real quick with chemotherapy? You talked about alkylating agents. Can you throw out, just for those of us that don't know, are there I don't know that about my chemo. I know the names of the chemotherapy. Like I had adriamycin and Taxotere. Do you know
Mhm.
any of those? Just for folks would that be
Yeah.
helpful if you threw out a few that maybe are kind of known that they might do that?
So the most common one, again, is cyclophosphamide. Other ones that are, frequently going to be used are like busulfan and carmocystine. I'd say those are the three most common. Um, okay. Brenda, were there other questions about any of that or things we should go back and hit?
I don't think so. That we do have some folks in here that are going through surgical menopause induced by I know you're getting there. So
Yeah. Okay, so the next question provided is what is the chance I'm going to go into menopause as a result of my treatment? And that's an incredibly difficult variable question to answer because it's highly dependent on the treatment. If you're a woman who has to have your ovaries removed, then yes, you are going to be menopausal when you wake up from that surgery. If you're a woman that is having radiation or chemo, then it can be a little bit more variable. And it's honestly probably a more appropriate question for your oncologist because they are the ones that are most experienced with the medications and the treatments. But I think one of the things to remember is when you go through treatment, it is not just the treatment that dictates what the chances of going into menopause. It is also, it's the treatment type, it is the treatment duration, and really importantly, it is where is that woman in time? So a 22-year-old and a 42-year-old could go through exactly the same treatment. And the 42-year-old's risk of becoming perimenopausal or menopausal is significantly higher than the 22-year-olds. And that's because she's closer to that point anyway. Like what that, especially chemotherapy, what it's doing is it's sort of destroying the healthy ovarian tissue or abnormally aging that healthy ovarian tissue. And if you're 20 years further along in that process, you don't have as much reserve as a younger woman does. And so although the 42-year-old might not be as worried about having a baby as the 22-year-old, she probably does still want to be making hormones and have that estrogen in her system. There are some medications that can be used to sort of help. We always like say, hide the ovaries from your chemotherapy. It's a class of medications called the GnRH agonists. And so people, their names are Lupron and Zoladex, right? And what these medications do is they shut down the activity of the ovary. And so they stop those eggs that are in the ovary from rapidly dividing. And when the eggs sort of like go to sleep and hibernate and are no longer rapidly dividing, they are not as susceptible to the chemotherapy. And so they can kind of hide from the effects of it. It's not perfect. It doesn't work for everyone. But it can lessen the effects of the chemotherapy. And you know, I would like to think that most women who are still in their reproductive years, it is discussed with them the use of Zoladex or Lupron prior to chemotherapy. I would like to think that. I could be wrong. We had a question that was, does early menopause equate to early aging? And in some ways, yes. I mean, I think the term early aging is a little challenging because there's kind of like a connotation there that we all have in our brain. And, you know, you hear early aging and all of a sudden you picture like an elderly woman with a walker. But the reality is, you know, one of the hallmarks of being a younger woman is that you have estrogen in your system. And when you go through menopause and you no longer have that estrogen, you can start to experience some of the things we associate with aging, right? Bone density starts to go down when there is no longer estrogen in a woman's body. And when bone density goes down, that puts women at risk for osteoporosis, or what is sort of considered pre-osteoporosis, osteopenia. When estrogen levels are lower absent, bad cholesterol goes up, LDL cholesterol. There are higher rates of high blood pressure. When you start combining high blood pressure and elevated cholesterol, you increase the chance of cardiovascular disease. And so, you know, these are all things we kind of associate with getting older. Menopause itself does not make people gain weight. The decreased metabolism that people have with aging does make people gain weight. And again, aging tends to go along with the perimenopause and being menopausal. And so those things can kind of be confused. What menopause does with weight is it shifts where the weight is going. So generally speaking, women collect more weight around their hips and thighs than men do. Once there is no longer estrogen in the system and women are perimenopausal, menopausal, they tend to collect it in their abdomen. You'll start hearing women talk about this little pooch they have that they just can't get rid of that was never there before. That is pretty common. Now, like starting estrogen will ward all of these things off. And so that's great if your cancer allows for that, right? And not all cancers allow for that. If you had an estrogen responsive breast cancer, your oncologist is not going to let you take estrogen. If you had endometrial cancer, your oncologist is not going to let you take unopposed estrogen. I would say with women who are surgically menopausal, it's going to depend on why the ovaries had to go, right? If there was a concern about the ovaries themselves, estrogen could be an issue. If ovaries were taken as part of a larger surgery or a more complicated surgery because of a colon issue or an appendiceal issue or something along those lines, that could be different. I mean, estrogen will really mitigate all of these effects. And generally speaking, if women go through menopause prior to sort of their natural age, 50, 51, it's recommended that they start estrogen therapy, but we have to balance that with keeping the cancer patient healthy. So although we don't want you to be aging prematurely, we also don't want your cancer to come back. And so that can be a line that you have to walk, like, with your oncology team. Question 4 was, what are the most common symptoms associated with menopause? And I guess for this, I would say menopause and the menopause transition, right? Because some of these symptoms we're going to talk about are a little bit more common when you're going through that menopausal transition or perimenopause, when the ovarian function is just going down, but is still there. Others are sort of start in that transition and can be persistent once you are fully menopausal. The most common symptoms that people complain about are the vasomotor symptoms: hot flashes, night sweats, difficulty sleeping. That's what people complain most commonly about. And that happens in response to highly fluctuant hormone levels. So hormone levels that are going up and down, up and down, up and down. That will sometimes happen to women after they have a baby. They deliver the baby, and that pregnancy and that placenta is no longer in their body, and their hormone levels crash. And as most women who have had a baby can tell you, they can feel that. And so it's not uncommon for women to have hot flashes after having a baby. Some women even have hot flashes associated with the onset of their period every month because their hormone levels are falling.
Give here.
Brenda, I think you're muted.
Yeah. Chris, do you have a question?
Oh.
Maybe
No.
she's, no, okay. We saw you came off of mute, so we just were wondering about that. And I do have a quick question, and this is for me. I had triple negative breast cancer, but I'm also now 61. So but if I was younger, that was probably would have been something I should have probably discussed with my doctor and say, should I or shouldn't I go down that road?
I mean, in a perfect world, right? I think as patients, we can only ask what we know to ask. Like, even for myself, if I were to get cancer, I would have to go to the oncologist and say, you need to talk to me like I'm not a doctor, because cancer is not my world on a day-to-day basis. Gynecology and hormones are. So I don't think I know things I don't know. I may not know what questions to ask. And that's the hard part, you know?
And one more symptom that I wanted to mention, I think other women have sometimes, is loss of hair, thinning.
Mhm.
It kind of goes into like a constant shed mode.
Yep, very common as estrogen levels go down. Along with hair loss, people will frequently complain of drier skin. I think one of the things that I'm hearing more and more from, like, my friends as we enter that period of our lives is the brain fog and difficulty focusing, sometimes difficulty with, like, word finding, losing track of where they are in the middle of a sentence, or, the proverbial, why did I walk into this room? Vaginal dryness is not uncommon. That's also an effect of low estrogen. And with that vaginal dryness can come pain with intercourse, as well as a greater susceptibility to bladder infections for some women. Migraines are not uncommon in the perimenopause. And that can be true for people who have never had migraines. All of a sudden, in their late 40s, they're getting these episodic migraines. So it can kind of run the gamut. And like most things in life, everybody's perimenopausal transition is a little different, and it is easier for some women than it is for others. The women that it is hardest for are the women who had their ovaries removed, because the rest of us get to go through a slower decline, right? And your body has a little bit more time to get used to, like, what is this new normal? And that is not true of a woman who goes to sleep and 2 hours later wakes up without her ovaries. That's a very hard thing to experience. And again, when we can, we like to put estrogen patches on those women before they even leave the recovery room. But certain cancers just don't allow for that. One of the questions was, are there medications that can help me with these symptoms? And we talked a little bit about this. I mean, like, estrogen will get rid of all these symptoms. But the better question is probably, well, what if estrogen's not an option? Like, what else is out there? And so you kind of have to tailor it to what's the complaint, what's the biggest symptom, what's the biggest problem, what is impacting your quality of life the most. And so if you're talking about, like, the hot flashes and the night sweats and all of the sleep disturbances that those result in, and you can't take estrogen, then the next second line medication would be it's a class of medications called the SSRIs or the SNRIs. And these are antidepressant, anti-anxiety medications. So things like Paxil, Lexapro, Celexa, Buspar, like Effexor, these all fall in to those classes of medication. And they can be fairly effective in reducing that symptomatology. There is about a 4 to 6 week onset of efficacy. So it's not the kind of thing where you can take it and you're going to necessarily sleep great that night, or where you can take it just when you need a really good night of sleep. Like, this is more of a preventative, I'm gonna take this every day, and hopefully moving forward, I will have better sleep because I do take it every day. There's a medication called gabapentin. The brand name for it is Neurontin, and it's actually an anti-seizure medication. It is also used for patients that have chronic pain. And what it does is it works with the neurotransmitters in your brain to sort of create a more relaxed state. Gabapentin tends to decrease anxiety and kind of create like a calming effect. And so people tend to sleep better. Clonidine is another one. This is an old-fashioned blood pressure medication. But same sort of thing. It opens up your blood vessels a little bit, drops your blood pressure, drops your heart rate. All of those things sort of create a calming effect. And when your vessels open up a little bit, especially like the vessels that supply the skin, it's easier for heat to come off your body, right? Anybody that has hot flashes will tell you it's not that their arms and their hands are hot. It's like there is all of a sudden a little stove inside their body or inside their head. And it's this very hot internal heat. And so if you can open up those vessels a little bit, it helps. One that's a little bit newer, I don't have as much experience with this, but I have some colleagues that have used it successfully, is something called oxybutynine. And this is actually a bladder drug. It's designed for bladder spasms and incontinence, like people who are leaking. But the thing that, like, all of these drugs sort of have in common is working to bring the system down, right? Like during the hot flash, during the night sweat, it's sort of like an elevated state of being in your body with temperature and neurons firing and all of these different things. And so trying to bring that back down to baseline or even below baseline where it should be when you're sleeping can be helpful. Um,
Dr. Oakes, we have a
yeah.
question. She says, I have appendiceal cancer. And can you expound on the concerns related to the surgical complete hysterectomy?
Okay, so it would depend on when the appendiceal cancer was diagnosed, right? So, um, it is, you can have an appendiceal cancer that's diagnosed because a patient is having a surgery and the appendix looks kind of funny. And so somebody takes it out, and in that appendix, even though like to the naked eye, it just kind of looks funny, um, there's a little tiny focus of cancer. Or you could have a much larger appendiceal cancer that doesn't cause problems until it becomes bigger. Um, the thing about the appendix is that it sits basically like next to the right fallopian tube and right ovary. And so sometimes as cancers grow, they can kind of like overtake other structures. And so it would just sort of depend on how advanced it was.
She said it had spread, so
Yeah. I think everybody's hope would be in that scenario because the left ovary is on the other side, that you could preserve that. And ovaries, like just as an aside, if you lose one, the other one will take over. And so, like losing one ovary, those women generally don't notice any sort of like disruption or anything like that in their cycles.
she unfortunately had to have a total hysterectomy.
Yeah, it sounds like it was pretty advanced.
Mhm. So I'm guessing that she's had quite the journey with,
Yeah.
again, like you talked about, just immediate, right? With immediate symptoms, etc. Um, if you would like to come off mute and ask Dr. Oakes a few more questions about that, you sure can. I don't want to out her. She doesn't
Oh,
want to be
no,
outed.
that's fine. And I appreciate you guys. Just when you were talking about the surgical hysterectomy, because that's what happened is they went in to remove an ovarian mass, and that's what basically they had found. It had originated from my appendix, but it had basically overtaken everything. And so they did the complete, but you had just made a comment about there being some concerns, I guess, and I might have misinterpreted it as far as, estrogen for somebody like me and that type of stuff. So I wanted you to expound on that a little bit.
Yeah, I mean, granted, I'm not an oncologist, but if the root cancer, the primary cancer is what the oncologists call it, is appendiceal, then that shouldn't be hormone driven. And I mean, the oncologists might jump up in arms about what I'm about to say, but I would think in that scenario, estrogen replacement would be fine.
Okay.
Appendiceal cancer is not really thought to be estrogen driven.
Right. And I've talked to him about it, and because I had a major surgery again in January, so now I'm like through treatment, so now I'm kind of to the point where I can finally deal with the menopause stuff.
Yeah.
And so we've talked at length, and he doesn't seem too concerned either, so that's why, like I said, I just wanted to kind of get your expertise on it too, since you're more familiar with the hormone part of it and that kind of thing. But he doesn't have any major concerns with estrogen replacement at this point for me.
Yeah. And I think, generally in that scenario, most like hormone doctors, gynecologists would say like estrogen, at least up until that point of like what would have been natural menopause, early 50s. And then you can sort of assess like, how am I feeling? You know, do I want to come down to, do I want to decrease the dose a little bit? Like I'm not 30 anymore. Maybe I shouldn't have the estrogen level of a 30-year-old. But you know, it's important for like all of those other reasons that we talked about. You want to be able to maintain your bones and keep your, like all your cardiovascular parameters good. You want your cholesterol to stay low and your blood pressure to stay low and all of those things.
Right. Okay. Thank you guys so much for letting me talk through my
Yes.
specific case. I appreciate that so much.
We have one other question that's very interesting. So earlier, Dr. Oates, you were kind of talking about, you know, putting the estrogen stopping drugs, right, to kind of calm things down. So this person said, you talk about the hormone taper and the cliff. Is there any point where after the estrogen is gone that you even out? Like if I hold on for X amount of time, better sleep will happen? Will that keep happening until I'm off the estrogen stopping drugs?
Okay. I'm not totally sure. So I think what we're asking is this is a patient who's taking Lupron and is wondering about.
It's me. I'm curious. Hi.
Hi.
I'm triple positive breast cancer. So
Okay.
there is no like hormone replacement option. Like I'm on
Right.
double duty drugs to make sure that this is no more production is happening, or they're trying to block it as much as possible. So like I'm menopausal. Sleeping stinks, and there's doesn't seem to be a lot that can be done about it besides drugs. So if I just hold out like in a year or two, will I get used to these drugs enough where some of that sleep will come back? I won't be woken up as much at night. Like, you know, I did kind of go off the cliff, but was my body going to adjust and figure it out and find a new normal, or not so much?
Can I ask you a personal question?
Sure.
How old are you?
I'm 44.
Okay.
I had some perimenopausal stuff prior that I knew was kind of starting. But when I started chemo, that was the day that started the year count, I guess.
I mean, when you talk about like the sleep stuff, the hot flashes, the night sweats, that tends to get better with time. At least say like for a patient who goes through like natural menopause, right? It seems to be the worst during the perimenopause. And then once a woman kind of just hits low estrogen and there aren't as many fluctuations, it tends to be a little bit better. I think the harder part for you is going to be that you may still be 7, 8 years out from that. And those medications that we use, like after the fact, things like anastrozole and some of the like tamoxifen and some of those medications, they don't, like, there's still estrogen there, right? They're designed to block it, but it's not as if it's not that there's no estrogen. And so I think you're going to probably have some of those fluctuations longer. And yes, potentially with time, your body may get used to that and sleep better. But those fluctuations are still going to be there, you know? And I think like, I mean, and here's the thing, there's another class of medications that help you sleep, things like Ambien. But now we're talking about things that like Ambien, Valium, Xanax, they will make you sleep, but they're also highly addictive. And they can kind of worsen some of the brain fog associated with low estrogen. And so if we can use medications that are less dangerous in that regard to try and get people through, that's everybody's preference. I mean, I wish I could tell you that like, oh yeah, give it a year and it will magically be better. And it may, but it may not.
That would be super cool if you could have, but
I know.
I kind of figured, like, it is
Yeah.
that constant struggle of I'm taking some medication to make all of this stop. And so it's constantly like breaking through, and
Right.
maybe just makes nighttime not awesome.
Yeah.
Dr.
Yeah.
Dr. Oakes, there's another question. I know you're getting to this, but I do think there's a lot of interest in this, and I'd love to kind of bring it up a little bit in your presentation. So someone was talking about having a radical hysterectomy. They don't have any ovaries or uterus. Her cancer is estrogen positive, so no hormones. She can't use SSRI. She doesn't tolerate them. She's she's tried gabapentin for pain, came off of it because it was too sedating. There's a lot of us that are wondering, are there any natural remedies you might recommend? You know, she said she's been adding flaxseed to food, sea buckthorn oil, evening primrose oil, and diet and raw food, vegan, all of those things. She was thrown into all of this at age 41. And of course, she's wondering again, I think you kind of just answered that. Is it going to, when is it going to end? Which is what we all want to know. But I think we do need to address kind of some of those natural
Yeah.
supplements that everyone, and also well-meaning friends always try to throw things at
Right.
us. So I think it's something important we should talk about.
Okay. Well, so yeah, let's talk about lifestyle. Okay, so the things, like in my experience, the three things that are most effective. Okay. And then I'm going to tell you these three, and then we'll kind of go through like a list of a whole bunch of different things. But most effective are going to be limiting or getting rid of alcohol and caffeine. Okay. Certainly if you're drinking caffeine, keeping it in the morning and not letting it stretch into the afternoon and evening, and then either eliminating alcohol or like keeping it to one drink. Exercise. There is so much documented science on the benefits of exercise in terms of like all of the different components of menopause. But I mean, women who like do regular weight bearing exercise, they tend to maintain their bone density. It elevates mood. People sleep better. They build muscle mass. It helps to maintain weight. And like all of those things are going to make the symptoms of menopause better. So yeah, so I guess the third thing I was going to say, which I sort of just said, was maintaining weight, right? Like trying to avoid gaining the weight that lots of people do as they get older, because that in and of itself is an independent risk factor for all those hot flashes and night sweats, like regardless of everything else. When you talk about like other dietary changes, lifestyle changes, supplements, I imagine that a lot of you have spent a lot of time like on Google, doing your own research, looking things up. What can I try? Taking lists to your doctor. Will this work? And one of the things you have probably learned is that you can find a study or a blog or an expert who will agree with anything, right? Like if you search hard enough, you're going to find something that says medication A works or supplement B works. And if you keep looking, you'll probably find something that says the exact opposite. And that is very, very true when it comes to lifestyle interventions and diet and supplements. But let's talk about some of them. Okay. So when you talk about dietary changes, there's a lot of different things that people have put out there. Most of it would be like low fat, high vegetable, like even vegan. Lots of soybeans, legumes, which to be clear are phytoestrogens or plant-based estrogens. And so again, if you have like an estrogen dependent cancer, that's something to consider. Like, should you be taking plant-based estrogens? Is that something that your oncology team is comfortable with? There was a NIH, the National Institute of Health, did a big study a couple years ago. And they showed an improvement in hot flashes when people went to a low-fat diet that was completely vegan and ate like half a cup. I can't remember if it was half a cup or a cup of cooked soybeans every day. Personally, that diet's not going to last super long in my house, but they did show improvement. There's some evidence that like increasing your fish intake, eating a diet high in omega-3s, so like those cold water fish, can be beneficial, especially in terms of like the brain fog. There are reports that focusing on eating unsaturated fats, so things like almonds and avocados and not McDonald's, going to be beneficial. Staying away from processed foods, again, McDonald's, Twinkies. I mean, this probably isn't rocket science. You're probably all thinking like, well, yeah, we know this stuff. We know we're supposed to eat that stuff. In terms of supplements, supplements are also hard in the United States. Supplements in the United States are not FDA regulated, right? Nobody is overseeing those companies to make sure what they're telling you is in that pill is in that pill, which can make it a little challenging to do research. But I think most people agree that taking some calcium and vitamin D is good for your bones, right? It doesn't necessarily build bone mass, but it helps to slow the breakdown of bone. So if you're perimenopausal, like 1,200 milligrams of calcium with about 600 international units of vitamin D. If you're premenopausal, so if you're in that transition, you can probably drop that down to about 1,000 milligrams of calcium and 300 to 400 units of vitamin D. A lot of the supplements you read about on the internet in terms of making hot flashes better are the phytoestrogens and the phytoprogesterones, right? And things like wild yam, red clover, raspberry root leaf, black cohosh. Black cohosh got a lot of press several years ago. And like just my own experience, my mom, breast cancer, was like, I'm taking black cohosh. And I'm like, you can't take black cohosh, that's an estrogen. Well, nobody told me that. Okay, well, do me a favor and at least call your oncologist and like run it by him, because some of those medications might be detrimental, right? And the most important thing is that your cancer doesn't come back, and you're here to have this conversation about how we can make the symptoms better. Ginseng, there's some stuff on ginseng, and interestingly, what they saw when they gave ginseng to menopausal women was that they had higher quality of life scores. So they would give them a survey and ask them all these questions, and they basically looked like they were happier on the ginseng. But with like individual symptoms, they didn't see a lot of improvement. I don't know, if you're happier, that's probably a good thing. St. John's wort has been reported to help some of the like mood symptoms associated with menopause and the perimenopause, because those, like, again, those hormonal fluctuations, they make people moody, they make them irritable, they make us anxious. And then if you tack that onto a cancer diagnosis, where it's very common to have some depressive symptoms or feelings of sadness about the fact that you have cancer and you have maybe lost your fertility and you're experiencing all this before you're supposed to have to, and this isn't fair, and like all of those feelings that people have. Sometimes the St. John's wort can help with that. When they put St. John's wort up against antidepressants, it doesn't do as well. but it's something that, you know, could be tried, especially if those antidepressants weren't effective. Do people have specific, like, I mean, anything you probably ask me, I'm going to be perfectly honest with you. Anything you probably ask me, is it safe for me to take this or will it help? The answer is going to look something like, well, you need to ask your oncologist. Because, like, right, just sitting here on Saturday morning, I don't have everybody's medical history and cancer types and stuff. And if they say, yeah, give it a try. Like, it's not going to hurt you. Give it a shot. But
Dr.
I'm
Oaks,
happy to take questions on specific ones.
Dr. Oaks, can I jump in real quick as well? Something else I want to remind everyone of. We all hear it, right? We all hear that diet and exercise make a big difference. And I can almost hear the collective groan, right? But it
Yeah.
is true. So a couple
Yeah.
things I want to recommend, some resources you may not be aware of. The Live Strong program. It is available to you at your local YMCA across the country. Check into it. Here in Omaha, it is completely 100% free. And also, they will give you a free membership to the Y as you're going through the program. Highly, highly recommend it because it's a way to get started. Very light, very gentle, but getting started is the hardest part. The other thing you can do is, it's just a suggestion, to get steps in. I know it's not really weight bearing exercise, but it's kind of sort of, at least again, getting started is the most important. Every time you get a phone call, I want you to get up and walk around and walk the whole time you're talking on the phone. You would not believe how your steps add up and you don't even notice. Your family's going to think you're crazy because they're going to think you're pacing. It's okay. So, but I really wanted to just jump in. Also, I'm going to promote one of our own programs that Dr. Oaks may not be aware about. We have a brain fog program here at A Time to Heal. It is available to you absolutely free. It's a 6-week program, once a week over 6 weeks, 90 minutes. That's available virtually for you. It has helped a lot of people. Brain fog, whether it's from chemo, menopause, both, or even COVID survivors have taken it and found it helpful. But best news is it's free. Not going to cost you a thing to try it and see. So that's my commercial. My commercial's over.
And my plug is, as a physical therapist here locally in Omaha, Methodist Hospital has a Monday through Friday exercise program that is needs-based, so essentially free. As a cancer survivor and a PT, I teach one of the classes. It's everything from light weights and aerobics to Tai Chi and yoga. But everybody at Time to Heal knows my name, and I'm happy to help assist. And the great thing is it's cancer only for cancer survivors, female or male. And so it's a great community environment as well.
I saw there was a question about vaginal dryness, and we kind of skipped over that as like one of the symptoms of menopause, at least in terms of talking about things that can make it better. But that one can really impact people's lives, and to be honest, really impact their marriage, or partnership. And so, I mean, there are easy things. There are like over-the-counter lubricants, right, that can be used at the time of intercourse. If you are someone who is potentially perimenopausal and hoping for a pregnancy, we would always tell you to try and buy a water-based lubricant and not a petroleum-based lubricant. Just because the petroleum-based lubricants will decrease the chance of pregnancy. There are also vaginal moisturizers that are not designed to be used with intercourse, but like a couple times a week. Like Replens is one that's available over the counter. There's a hormone called the hormone is called DHEA. right? And that is a naturally occurring hormone in everybody's body. It's an androgen, so it's what we think of more as like a male hormone. But there is some work on vaginal DHEA medication. And that should be safe even for women that have estrogen dependent cancers. Libido is sometimes treated with testosterone. That is not an FDA approved way of using testosterone. And inside of the female body, testosterone is converted to estrogen. So you have to be careful about cancer patients using testosterone because you, again, like inadvertently could be taking in estrogen. And the hormone DHEA should not do that. There's also a medication called, let's see, the generic is ospemifene. It's OSPHENA. That's the brand name. Osphena. I'm probably saying it wrong. But it's a medication that falls under the umbrella of selective estrogen receptor modulators. That's a class of drugs that is commonly used in estrogen-driven cancers. And that has been shown to be beneficial for vaginal dryness and libido and pain that goes along with intercourse and some of that stuff. Let's see. There was questions about bone density and will menopause affect my bone density? And honestly, the simplest answer is yes. And I wish I could give you a different answer, but estrogen keeps our bones strong, and all people eventually get to a point where they don't have as much estrogen in their system and the bones start to weaken. So the most important thing you can do is try and slow the degradation or the breakdown of the bone that you have left, right? Bone is continually building up until about the age of 30. That's when women hit peak bone mass is 30. And after that, that building up starts to slow and we start to degrade bone. Again, estrogen will help keep that from happening. But if you can't take estrogen, that's not an answer. And so for those patients, we might use things like the medicine I was just talking about, the SERMs. We can use tamoxifen, which is actually really interesting in that it blocks estrogen effect at the breast. So it's safe for breast cancer patients, but it helps build up estrogen activity in the bone and the brain. So that's an option. There's a class of drugs called the bisphosphonates. This is going to be things like Fosamax, Actonel, Boniva. You know, you see these commercials on TV. They can help slow the degradation of bone as well. But the one sticky point is that those medications sort of get like incorporated into the architecture of the actual bone to help strengthen it and slow that degradation. Over time, they kind of leach back out. And that's okay for us. It's not okay if you're pregnant. And so those medications cannot be used in women that might at some point carry a pregnancy in the future. If that's off the table, carrying a pregnancy, by all means, those are good medications to help your bones stay strong. There was kind of a sub question to the bone density DEXA scan question, which was, should I have a DEXA scan before I start treatment? And here's my thoughts. Is that going to hurt anything? No. But that's not what's most important in that interval of time when you have been diagnosed with cancer and when you're getting ready to start treatment. And I don't think a patient should let their bone density drive their cancer treatment. I think the more important thing is to treat the cancer and hopefully cure the cancer, or at least put it into remission so that you're here long-term and we can subsequently worry about your bone density. But if you don't treat the cancer and the cancer gets you, the bone density doesn't matter, you know? Like, we have to sort of like prioritize at that point. I think, go ahead, Brenda.
I'm so
Sorry.
sorry. So we are at 11:03. Oh, here's a question. Bone density. My PCP had me do a bone density test to get a baseline, which is I think what the original kind of question was about. And I'm on a calcium D3 and K2 supplement, 900 to 1200 milligrams daily. She's careful not to take with supplements or drugs that calcium can impact. That's very smart. PCP also recommends weight-bearing exercise, which as cancer patients, we all know is so hard, but so important. So it was more of a comment than anything else, but that's so true. One thing I was going to suggest is, I know we have, there was a question about options to preserve fertility, but I also know you have a couple more that are more questions that are more related to perimenopause, et cetera. You know, I'm thinking about 10 and 11, Dr. Oakes. So we don't have a lot of time left. I, for one, I don't know about anyone else, I would love a part 2, just about fertility and preserving, how to preserve fertility, either going into cancer treatment or other things you should be doing after. If anyone is interested in a part 2 from Dr. Oakes, where she can expand more maybe on that topic, because we are quickly running out of time. I would love to schedule that with her, and another webinar, you know, maybe in November or December, we could do that. So let me know if you're interested in that. So go ahead, Dr. Oakes. I just wanted to throw that out there because I know there's just so much to cover. So many great conversations to be had.
Yeah, I mean, I agree. I think that the fertility part of it, gosh, we could easily spend a whole hour talking about that. And admittedly that might be a little bit of a different patient population. We might get some people that today are not as interested in that and people that would join that are more interested in that. You know, the last question that was posed was regarding mental health issues. And I think we have kind of talked about that in other ways, but you know, does being menopausal or being in the perimenopause put me at higher risk for mental health issues? And to some extent, yeah, right? Like it can cause moodiness and anxiety, and not sleeping at night and not feeling good can make people feel kind of depressed and lower their quality of life. I will say that's like different in some ways than like a clinical depression. But yeah, there are a lot of mood symptoms that go along with this, and certainly having those feelings of sadness and depression related to the loss of youth or the loss of fertility or the fact that you have cancer would all be very, very normal. I think we hit most of the questions you sent me, Brenda. I don't know if people have more questions out there that they wanted to ask, or.
Yeah, folks, we have just a few minutes left, so please, if you want to come off mute and ask some questions, and I think Becky maybe has a question.
Well, I kind of put it in the chat, but maybe it got skipped. So I chemo-induced menopause, which I didn't know about at 34. And then I'm now 44 and just kind of started the fight to be on estrogen. So about a month ago, I got started on estrogen patches, and blood work shows that menopause happened a long time ago. Are there different doses, or could you, is there a possibility to be on like a vaginal estrogen?
Yeah.
In addition to the patches?
There's lots of different doses. And there's lots of different routes of administration, right? So there's pills, there's patches, there is a vaginal ring that is generally used more for the vaginal symptoms, the dryness and pain with intercourse. Systemic levels of absorption do not get as high with that vaginal ring as they do with the patch and the pills. I think generally people gravitate towards the patch because when you take pills, there is sort of this like peaking and troughing phenomena, right? Like you take the pill and your estrogen levels shoot really high and then it falls. And then you take a pill and then it falls. And because the patches are more of like a slow time release, you get a little bit more even keel. But even with those, there are different doses and you can have people like double up. It's kind of experimenting with it, right? And admittedly, every physician may not be as comfortable with this. But like
For some reason, my OB, which is new because the last one retired that helped me through all of this, was very uncomfortable. Even I do not have there's no issues with an estrogen-based cancer. It was like talking him into it for 6 months.
Yeah.
So I'm like, I feel so much better even after 2 months. And I'm like, wow, I can stay awake now. And I'm like, well, what if I could actually like really stay awake? Like if I could stay awake and I don't have to sleep for 3 hours in the afternoon, but I still have to sleep for an hour.
Mhm.
Can I make this better?
Yeah, I
will
mean,
a vaginal estrogen improve my libido?
I don't know that it will improve libido.
Okay.
It might. And
I
that
mean,
would
I
be
just kind of like maybe at this point just want to like put it all over my body.
right. Bathe in estrogen. I mean, it's not what you want to watch for, right? Is if women are on too much estrogen, theoretically, they put themselves at risk for blood clots, right? And
Okay.
blood clots can travel to the lungs and blood clots can travel to the brain and result in strokes, and that's not good. And so it's sort of like walking this line, right? The ideal dose is the lowest dose that results in symptom improvement or resolution.
So what's that starting dose and what can you go up to just so for my research?
Well, so it kind of like if you're using a patch, there's
A patch, yeah.
like the two most common patches are Climera and Vivell.
Mine's the Climera.
Okay. And so generally it would be like a 0.1 and then there's like a 0.2 patch.
Okay.
And again, like you can even play with that and people can wear more than one patch. You just, again, want to be mindful of like, okay, how much estrogen does this equate to in their system? And do we reasonably think that's safe? Libido is super multifactorial, and there's so many issues that play into libido. Actually, the bulk of the issues that play into libido are not related to hormones.
Okay.
But certainly if it's painful to have intercourse, nobody's going to have a great libido. And estrogen may help in that regard.
Okay. No, it's just like, I love my husband, but I'd rather go to sleep sometime, most of the time, sort of thing. But that's totally, I just wanted to know if that had helped anything. So perfect. Thank you.
Yeah.
It was not all oncologists are like back in 2014, we were trying to stay alive. And I think they mentioned that that's a possibility, but it didn't stick. And certainly because I have a rare cancer, it was mostly how to stay alive and none of the follow-up. So it's definitely frustrating. That's been a little bit of a reach out and research on your own, because prior to this point, everything was like because bone marrow transplants, blah blah, clinical trials and things like that. It was all my symptoms were related to that. But I believe if I would have been on estrogen 10 years ago, a lot of this would have become fixed too.
Yeah,
But nobody was thinking that at 35.
right. No, and they're like, this is probably more information than anybody wants to know. But in 2001, there was a big study that came out. The WHO, the World Health Organization, released a study. And basically, the study was like, estrogen's bad. That was basically the result of the study, is estrogen's bad. So anybody who trained from like about 2001 through about 2015, which is a lot of physicians, was trained that estrogen is bad. Estrogen hurts people. Estrogen is bad.
And
the
I
study
think
has
here in
been-
the Midwest, it's still that way.
it's been a very slow. The study's been redone. It was reanalyzed. There's all these nuances and caveats like there is to everything in life. And it's not bad for everyone.
I've had
And
multiple doctors pull out that study.
Yeah.
And still,
But it's been a
Okay.
very hard, very big shift to get people to like really honestly reframe their whole way of thinking about estrogen.
okay. So keep trying.
Absolutely. And this really brings home, we're going to wrap up here, but have conversations with your doctor, even if they're challenging ones. Voice your concerns, go get that second opinion. I'm so glad we have these webinars and have experts like Dr. Oakes available so that you can ask these questions. And we're just so delighted. Everyone's been so interactive. I think we definitely need to have a part 2. You need to help me convince Dr. Oakes. So please put it in the chat if you would love to see a part 2, and maybe we can convince her to do that. I want to thank you all for like you said, giving up your Saturday morning. And if you even have some follow-up questions, you can go ahead and email those to me at info@atth.org, and I will pass those on to Dr. Oakes, and she can reach out to you directly and do some follow-up, because I know this has just been so great. Everyone's been so engaged, and we really appreciate you. So Dr. Oakes, thank you again.
Yeah, thank you for the invitation.
We just are so grateful. I'm going to go ahead and stop recording.